I'm reminded of what is perhaps an apocryphal story of a person who was asked to speak before the Texas Medical Association. And they introduced him about his credentials, and he had done this, and he had done that. And about 5 minutes into the introduction, a good old boy from the back of the room said, "Hell, we don't want to breed him, we just want to hear him talk." So I'm not sure you really want to hear me talk all that much, because there are some very pretty boxes here. But it is really worth noting, if you're like me, you've been inundated by the 10th anniversary news of another event. And as someone who was born and raised in New York, and whose family lived in New York on September 11th, 2001, that hit me hard as it hit all of us. But it did get me to thinking about 10 years ago. And although many of the people in the room have been with each other and with me in that time, it's actually changed a lot. So 10 years ago, the president was a guy named George Bush, and the governor was a guy named Gray Davis. The headline of the San Francisco Chronicle announced that Barry Bonds had hit 3 home runs that day. And the LA Times carried a breathless story that said there was a new device, a drug-coated stent, that showed great promise in keeping arteries open, and millions of people around the world were poised to benefit from it. And the story said, and I quote, "Although cardiologists heralded the finding, some cautioned that the results were almost too good to be true." 10 years ago, an ACO stood for the Australian Chamber Orchestra, or perhaps the Allied Command Operation of NATO. And healthcare reform, frankly, was really not on the national agenda. So now, fast forward to now. I have good news for you, and then bad news, and then more good news, and then more bad news, and then I'm going to tell you how you can save the country. The good news is that despite all odds, the Affordable Care Act passed, probably the most significant piece of social legislation in 40-plus years. And with fits and starts, and with some false starts, and with some revisions, it's on the way to being implemented. And that's hugely supportive for the aims of this group and of the foundation. The bad news, of course, is that the things that gave rise to the ACA in the first place are substantially worse than they were 10 years ago. It turns out even periods of prosperity do not necessarily get people insured in America. And in that decade, the IOM and others have pointed out just how inconsistent and unreliable our system is, and those of us who work in the system or who have families who have been patients in the system are all too aware of the gap between the greatest healthcare system in the world rhetoric and reality in some conditions for some people in some places, and the lack of a system-wide effort to hold our system to that standard. And the cost. I am notorious in some circles for saying it's got to be cheaper. All these words that providers use, these weasel words like value and bend the curve and slow down the rate of rise. The healthcare system of which we are a part has priced itself out of the reach of people who need it. That's just the plain fact. In 1970, Richard Nixon, a conservative Republican president, called for universal health care in the United States funded by an employer mandate. In 1970, the cost of a family high-option plan was 15% of the then minimum wage. In 2011, it is 115% of the minimum wage. Our system has priced itself out of the reach of people who need it. Some of you are familiar with an article that appeared in Health Affairs just this week that says in the last decade, in the 10 years of this program, virtually all of the economic progress that might have been made by the average American family has been eaten up by the increase in healthcare costs. All of it. That's bad news. So what's the reaction to this in our system? 2 days ago, the American Hospital Association, in response to the growing pressure on Medicare, unveiled its plan to contain Medicare costs. Anybody know what its plan was? To delay Medicare eligibility for 2 years. True story. Let's take it out of the old folks for a couple of years more. So the fact of the matter is that our system has now become so expensive that a political reality that would have been unthinkable when this program started has come to pass, which is to say that every serious politician in Washington says we got to control the cost of health care. From Paul Ryan to Paul Krugman, they may argue about how, but they're not arguing about whether. And demagoguery aside, there is broad agreement across the political spectrum on very little but this: healthcare costs have to come down. That's really a watershed in American healthcare politics. It's the end of an era in some ways. It's the death of a paradigm, and like all deaths, we in healthcare go through Kubler-Ross's stages. And the response of the AHA, it seems to me, is somewhere in between denial and bargaining. The good news, of course, is that there are some of us who have moved beyond bargaining to acceptance and even embracing of the changes that can happen to make our system both more reliable, more effective, more responsive, and I will say it, more affordable for people. That's the task that faces you. My sense is, and you can correct me if I'm wrong, when I go to medical staff meetings and hospital board meetings and community clinic conferences, there is more excitement and enthusiasm about changing the way we do things than I've seen in my career. There's trepidation about the future, to be sure. There's still some grumbling. But people seem to be grasping that the future will not be like the past, and there is huge hunger to get on with the task of making things both better and cheaper. So that's good news, because that's what you're about. But the bad news is it's not going to be easy. So as a participant in the Clinton healthcare reform task forces, I know how easy it is to dream up lovely concepts when you're sitting in a conference room at the Willard Hotel. And the difference between these concepts as they wind their way through policy battles in Washington and how they actually take place on Unit 4D or Thursday morning clinic is a big gap. But that's your job, is to bridge that gap. That's all of our job. Ed quoted Santayana. I will quote Yogi Berra. Theory and practice are exactly the same, except in practice. Or I have another friend named Gene who says the 5 most dangerous words in the English language are all you gotta do is. So I hope I'm not sounding grandiose when I say that the fiscal future of the Republic depends on our ability to restrain healthcare costs, to deliver effective, more efficient care at financial levels that will be a strain on the current system. If we cannot do that, the Republic is actually in peril. Now, I don't believe that the Republic will go down on that. I believe that in the absence of our ability to figure out how to do it, the cuts will simply be made because there is no choice. And if you don't think that cuts that have to be made when there is no choice can have dramatic and catastrophic results, go ask your friends at Bear Stearns. Oh. Well, go ask your friends at Lehman Brothers. Oh. My point is, we're in a race against time. I truly believe that we're in a race against time to figure out how to reorganize our system in such a way that it can meet the mission that we all signed up for and not bankrupt the rest of the country in the process. So, how will you save the country? There are 7 things on the to-do list to save the country, and 4 of them are right in your wheelhouse. The first is that we have to change what we do. We, all of us, day to day, we're seeing patients, we're trying to do the best we can, but our institutions and our business model is set up to reward volume rather than outcomes. So we've got to change what we do from focusing on volumes to focusing on outcomes, and in particular start focusing on outcomes that are important to patients. Second, we have to change how we get paid for what we do. Because to the extent that we, like most humans, do what we are incented to do, as long as the reimbursement system incents us for volume, we will follow down that track. So even as we're trying to figure out how to do things differently, we've got to figure out how to pay people differently so that they can do things differently. And then task number 3 is to figure out how to create new business forms and new business arrangements to accept these changes in payment for changes in what we do. ACOs, bundle payments, medical homes, all of these are new things. We'll need to be in a period of great experimentation in the next 5, 10, 15 years to figure out how to do this because, frankly, anybody who tells you they know is either silly or lying. The 4th thing is the first of the 4 that it seems to me are really very much part of what you've been about for 10 years, and I suspect will be about for the rest of our professional lives. Learning to work in teams and to maximize the potential contributions of everybody who's part of the care system, including patients. Now, some of you heard me say before, I'm old enough to remember when you had to go to the bank by 3 o'clock on a Friday afternoon if you wanted to have a good weekend. That's just the way it worked. There's virtually nothing that we do the way we did 15 years ago. We don't bank, we don't shop, we don't communicate with our friends and family, we don't manage our money, we don't make travel arrangements, we don't get news and information. We don't do anything the way we did 15 years ago except healthcare. Oh, we have new boxes, we have machines that whir and spin and gyrate and light up. But the basic interactive model of healthcare is virtually unchanged. If you think about the things that less well-educated people, including all of us are lay people as far as travel arrangements are concerned. If you think about the things that we do as lay people compared to what we needed expensive, highly trained people to do for us 15 years ago, it's astonishing how many of those positions have disappeared except for healthcare. And in my view, there is no way that this system can be affordable if it continues to be the last outpost of guild mentalities and protectionism in skill levels. So whether it's doctors to nurses, registered nurses to LVNs, LVNs to med techs, or professionals to patients themselves, and even more threateningly, humans to machines. We've got to figure out ways to take maximum advantage of everybody who's part of this system and stop relying on the notion that your numbers of years in school and training determine what you do. Task number 5, to incorporate management science in our everyday work, to pay close, thoughtful attention to what we do day by day, unit by unit, patient by patient. Let me tell you a little bit about where this program came from in my experience. I was a Robert Wood Johnson Clinical Scholar. The Robert Wood Johnson Clinical Scholars program was really a great program that took people who had finished their medical training and gave them the opportunity to get trained in some other discipline that was important to their leadership capacity that was not medical. So some of my colleagues trained in history or philosophy, became ethicists. Some are economists, some are statisticians, sociologists, anthropologists, communications people, people in business. The people who are in this program created the fields of general internal medicine and general pediatrics. They really changed the face of medicine. And what it took was enough dedication in human capital of those of us who are lucky enough to participate in it to say, you know, just because you're a doctor and you've been smart doesn't necessarily mean you can do medical history. You've got to get history training to do medical history. You've got to get anthropology training to be a medical anthropologist. So that was one experience that was profoundly impactful for me. And another was that early on in the history of the foundation, we made the decision that we were going to invest in the development of our senior staff and send them all to the Center for Creative Leadership, an institution you know well. So we all went through the 360, which was painful for us as it is for you. And we all went through coaching, and we went through these things. And in my cohort were people who were people of substantial management responsibility. It was the SVP of the Weather Channel and the head of the PX for the Southern United States, and people who were mid-careers, 40s, 50s. For none of them was it their first week or 2-week-long intensive management experience. No other industry would put somebody in charge of money without giving them some training, let alone lives. And yet in healthcare, we continue with this notion that if you're a smart pharmacist, we'll put you in charge of the pharmacy. Or if you're a doctor, we'll put you in charge of something just because you were the last person to step back when they asked for volunteers. So it was really profoundly influential to see to me that in other industries where, frankly, there was less at stake, they paid attention to the training and the grooming and the management of the management capabilities and skills of people who were charged with leading people and doing strategy and execution. And so in some ways, at least in my mind, this program grows from that twin set of insights of the importance of the investment in human capital and in training to do something, and in particular, training of the people whose job it will be to carry out these enormous changes in healthcare that we all anticipate and want, but which are not, as Ed said to me a couple of weeks ago, these things, these ACOs, these medical homes, these are not self-executing files. These are not things that happen on their own. They don't just kind of occur spontaneously. They take people with skills to do them and dedication to the task. The sixth is to learn evidence and adopt evidence-based practice more quickly, and the converse, to adopt new stuff more cautiously. 2 days ago, there was an article, an editorial in the New York Times about the fact that over the last several years, some of our colleagues have been furiously putting in stents into patients' carotid arteries, a new whiz-bang, gee-whiz technique, which turns out to be profoundly harmful to patients. And yet, 150 years after Semmelweis, we cannot get people to wash their hands. Does it strike you as ironic that as in quality, where we have overuse side by side with underuse, we have accelerated, precipitous learning and adoption of some things with very little evidence, side by side with the most maddeningly slow adoption of things for which there's decades, sometimes centuries of evidence side by side. So the capacity of this system to learn quickly, to not have to reinvent every lesson in every institution, has to be accelerated. And lastly, and perhaps the most difficult task, while all these other things are being done, to maintain a relentless focus on making things more affordable, because we do not have enough time or money for centers of excellence. We have to make do with centers of good enoughness. For those of you who think that in American healthcare we can ever be concerned about improving quality without reference to cost, those days will not happen in my lifetime, nor I suspect yours. So the reality is we've built ourselves a hole, folks. We built our system a hole from which we must collectively dig ourselves out. And part of digging ourselves out is figuring out how to do all these things while at the same time being quite clear that money is an object. It may not be for us, but it is for the people who can't afford our services, let alone our services and job training and mass transit and education and all the other social services that those same uninsured, underinsured, sick people need, for which our society's resources are increasingly taxed. So, it may sound hyperbolic, perhaps grandiose, but for those of us who've been at this a while, we really are depending on you to save the country. And I know some of you are looking a little long in the tooth yourselves. It's not like you're necessarily at the beginning of your careers, but you are in the places and spots where this transformation will have to happen. It will not happen on its own. It will happen because people are dedicated to the task, because people have built connections and trust among themselves and with each other, which is part of the perhaps unintended but nonetheless magical product of this fellowship, and because they have some skills to bring to bear on the task. So, I know I haven't been perhaps witty or as provocative as I might have been, but it's humbling to see the work that you've done in the last 10 years, and it's inspiring, frankly, to hear you talk through the quality improvement projects, and it's gratifying to see the product of our investment in you. So I want to thank, if Ed and I, in some strange biological way, were the parents of this program, Al was its midwife. I want to thank Al, I want to thank Victor, I want to thank George, I want to thank Sally, and the other staff who do the day-to-day work, but most of all, I want to thank Ed for his steadfast leadership and his vision and his ability to see the program change and evolve as you have changed and evolved and as the world has changed and evolved. And I want to leave you with this. I'm really not being hyperbolic when I say the future of this system is in the hands of those of you in this room and people like you who have to carry out the day-to-day, on-the-ground execution of these big policy changes that we want to see happen. They're not going to happen by themselves, and they're not going to happen easily. They're going to happen because people are dedicated to making the system better and to carrying it out and have the skills to do it. So I know I was talking with one of your wives earlier who was saying rightly that, it's a lot of time. It's a lot of time spent away from your family. It's a lot of time spent away from your children, from your hobbies, from your other obligations. It's a lot of time, and we appreciate the time you've put in. But for better or worse, it's not like your job is now over. Those of you who are finishing, as your alumni colleagues can tell you, we're facing what is, I think, the most terrifying and yet exhilarating period in American healthcare in my memory, because all these things are before us, and they're really going to be up to you to execute on. So we're proud of you. We're grateful for the effort that you've put in. We have great confidence in you. We've invested a lot in you. We're counting on you. Don't screw it up. Thank you.